Okay, let's dive right into this. Welcome back to another confused neuron explainer. Today, we're taking a fast-paced, honestly fascinating journey into the intersection of aggressive medicine and our body's most ancient protective mechanisms.
But before we get into all the complex pharmacology, let me ask you a very real question. What is the most dangerous thing about vomiting? Seriously, just think about it for a second.
It's not just the sheer discomfort, right? The two absolute biggest dangers are electrolyte imbalance and volume depletion. When you aggressively lose that fluid and those crucial ions, especially potassium, it can literally trigger life-threatening cardiac arrhythmias and even brain seizures. So right out of the gate, we're dealing with incredibly high-stakes medicine here.
Section 1. The chemotherapy battle. Aggressive medicine.
So, one of the primary triggers for severe, intractable vomiting in modern medicine is our fight against cancer. To really grasp why chemotherapy has to be so aggressive, we've got to look at the log-kill phenomenon. Chemotherapy destroys cancer cells following first-order kinetics. This basically means a given dose destroys a constant fraction of cells, not an absolute number. Picture this. If I were drawing a massive tumor on a whiteboard, a 5-log kill wipes out a staggering 99.999% of it. Sounds like a total victory, right? Well, actually, that tiny fraction left behind, say going from 1 billion malignant cells down to 10,000, still needs to be completely wiped out. And that requires multiple, relentless cycles of highly toxic therapy.
To hunt down those remaining cells, oncologists coordinate a very precise attack. They use cell cycle-specific drugs, like paclitaxel or bleomycin, that only hit cells when they're actively dividing. And then you pair them with cell cycle non-specific drugs, like cyclophosphamide. These act like an absolute carpet bomb on resting and dividing cells alike. It's a beautifully coordinated attack to maximize cancer cell death.
Section 2. The double-edged sword. Chemo's toxic toll. Now, there is a tragic irony to this powerful chemical warfare. You see, chemotherapy doesn't have a magical built-in GPS that only finds cancer. It targets any rapidly dividing cell in your body. So while it's destroying malignant tumors, it's inadvertently wiping out normal, healthy, rapidly dividing cells too. Your hair follicles, destroyed, leading to hair loss. Your bone marrow, suppressed, leading to anemia. And absolutely crucial to our explainer today, the cells lining your gastrointestinal tract are rapidly dividing too. That means they get completely shredded, causing severe irritation and profound nausea.
Which brings us to this incredibly fun graphic. Absolutely love this visual. It's essentially the mascot for our confused neuron channel. Your GI tract is being bombarded by toxins, and your vagus nerve starts firing panic signals up to the brain. The central nervous system is basically this confused neuron right here, scratching its head, trying to make sense of all these life-saving yet highly toxic chemicals circulating in the blood. And what is its ancient, evolutionary response to ingesting what it perceives as poison? Get it out. Immediately.
Section 3. The anatomy of a puke, the vomiting reflex. Let's map out exactly how your body orchestrates this.
The entire operation centers right in the brainstem. Specifically, the chemoreceptor trigger zone, or CTZ, located in the medulla oblongata. Think of the medulla as the command center for your vital reflexes, things like breathing and swallowing. When those chemotoxins hit the bloodstream or irritate your gut, they trigger the CTZ. So as a student of pharmacology, you literally have to, and I'd highlight this if I had a marker, get in the zone, the medulla oblongata, to really understand vomiting.
Okay, let's walk through the entire reflex arc from stomach irritation to the physical response. You can easily memorize this with the mnemonic SRACR. SRACR. And here's a fun fact from our source text. Sarasir actually sounds like the Arabic word for cockroaches. Pretty memorable, right? So you have the stimulus hitting the receptor, traveling up the afferent vagus nerve directly to the center in the medulla. The efferent nerves carry the command down to the diaphragm and abdominal muscles, resulting in the final physical response, the puke.
But remember, your brain prepares your body before the main event even happens. Look at these anticipatory responses controlled by the cerebral cortex. We're talking nausea, intense sweating, hypersalivation. It's just like the classic anecdote of the terrified first-year doofus medical student encountering a cadaver for the very first time. The brain anticipates the gross event, and the cortex triggers the nausea before anything physical has even occurred.
Section 4. The antiemetic arsenal. Pharmacological cures. Now, since we completely understand the biological problem, we can deploy the pharmacological solution. Because we know exactly which receptors trigger that vomiting center in the medulla, we can use specific chemical agents to block them. We can target serotonin 3, dopamine D2,
histaminic H1, muscarinic M1, and neurokinin 1 receptors. Shutting these down essentially unplugs the vagus nerve and the CTZ. It stops the reflex dead in its tracks.
Let's focus on a massive heavy hitter in oncology, serotonin 3. A great way to remember this is the mnemonic I always vomit on 3. 1, 2, 3. Puke. Drugs ending in the suffix cetron, like ondansetron, are 5-HT3 receptor antagonists. They are absolutely crucial for blocking that severe vagus nerve irritation caused by the chemotherapy in the gut.
Next up, we have metoclopramide. This is a D2 or dopaminergic receptor antagonist. It specifically targets the CTZ in the brainstem so you don't get in the zone of vomiting. But here is the major clinical catch, and we have to be very, very careful here. Blocking dopamine in the brain can unfortunately lead to extrapyramidal, Parkinson-like side effects. We're talking severe rigidity or tremors. So it's highly effective for sure, but we have to use it with immense care.
We also have auxiliary therapies to quickly round out the arsenal. Oncologists absolutely love using corticosteroids because, almost like magic, they boost the action of other primary antiemetics like ondansetron. We also use benzodiazepines, which are sedatives, to calm the cerebral cortex and literally stop that anticipatory nausea before a chemo session even begins. And for those incredibly stubborn, refractory cases, cannabinoids can be deployed as a powerful last resort.
Section 5. The clinical takeaway. Putting it together. I want to share this profound quote from Dr. Thomas Sowell with you. Ideas are everywhere, but knowledge is rare. Truly understanding the interconnectedness of chemotherapy kinetics, neuroanatomy, like the medulla, and receptor pharmacology, well, that's what separates a good learner from a truly great one. You aren't just memorizing a list of drug names on a whiteboard. You are actively tracing a chemical signal from a dying gut cell all the way up to a confused neuron in the brainstem. Which leaves us with this final provocative thought. Can we completely master the brain's oldest protective reflexes to survive our most toxic yet life-saving cures? We've mapped the anatomy of a puke, and we've built an incredible antiemetic arsenal. But the beautiful, complex balancing act of pharmacology is an ever-evolving frontier. I encourage you to keep diving into the source material, keep asking questions, and keep learning. Thanks for joining me on today's Confused Neuron Explainer.